All right. So good morning, everybody. So we are doing a trial run of the academic programs here in our ward, and this is a topic that I presented yesterday. For those who missed it or missed the discussion part, I thought of repeating it. Dissociative disorders is rather a contentious diagnosis. It's something people do not quite, some people do not agree with the concept of dissociation, and some people are more sold into it. So I thought it's an opportunity for all of us to be aware of this condition, so that it will be helping us in our day-to-day clinical practice, both for the nurses, psychologists, social workers, and everybody. So thank you once again for coming here. So today we'll be discussing briefly, this is my outline, case vignette. We'll be discussing the types of dissociative disorders, definitions of dissociations and dissociative disorders, etiology of dissociative disorders, diagnosis, clinical features, and management. It might look a bit bookish, but I'll try to make it as engaging, as interactive as possible. We'll be finishing, if we go in right time, within half an hour, including 5 minutes or 10 minutes of discussion. So let's go directly to the case vignettes. The typical case. In fact, I had taken from this ward this particular patient, 23-year-old Ethiopian housemaid brought by police with complaints of wandering around in the streets of Dubai. Some of you who have been posted here might be knowing. I'm not mentioning her name because the video would be out elsewhere for the sake of privacy. Well, she refused to discuss the problems with her treating team initially, but collaterals from the sponsors revealed that her behavior change was abrupt following a phone call she received from her boyfriend that he deserted her. She was seen to be speaking and grunting in a tone not understandable even to the translators. She apparently became almost mute and fearful before absconding from her employer. That's the history that we got. She was only given PRN medications and counseling by the psychologist. She had a very gradual recovery and later narrated the story of being jilted by her boyfriend in more detail. She further mentioned that her mother, who was divorced from her aggressive alcoholic father when she was 8 years of age. She was discharged after 7 days of admissions with no medications and returned back to her home country with escorts from the Ethiopian embassy. So I could have discussed about the possibility of the diagnosis, but probably we'll reserve it till the end of our discussion, so that we'll be more informed to discuss about it. You can interrupt me if you like, if it's a burning question, otherwise at the end we'll have some time for discussion. Alright, so essentially, when we're talking about dissociation, the name, a literally English word, is disassociation, it looks like, isn't it? So this is considered as the typical dictionary meaning is a disruption in the normally integrated functions of identity, consciousness, memory, and perceptions. Those mental faculties, instead of being associated, they are dissociated. In one of my earlier slides, probably it's not here, I had made a distinction between dissociation versus association, because that association is not necessarily talked about, but that is necessary for a mental functioning. So this condition should not be due to the effect of the substance or general medical conditions, and it results in amnesia, depersonalization, and multiple personalities in the same individual. We'll be discussing those things in more detail. This is just a teaser. So the common dissociative experiences in everyday life, I mentioned it here to bring home the fact that dissociation is not uncommon. We do in various situations in our life experience it. Many of you might be remembering it's a very common feature. Yesterday we were discussing how some of the common human experiences are labeled as mental illness. It shouldn't be the case, and we'll be discussing about it. I'm not reading the entire list, but those are all mentioned, as you can see here, including remembering the past so vividly that you seem to be reliving it sometimes. Okay, so now let's look at the possible causes of dissociation. One of the most important cause that when you are fatigued, didn't sleep for a few days, for example, and stress, binge drinking, drug abuse, drug use, and a new environment that you come to office or a new job, suddenly things appear unreal. All right? So these are the dissociation as symptoms, not necessarily diagnosis. So we are coming to that. So making a diagnosis of dissociative disorder will require something in bit more intensity, a bit more for a consistent period of time. So dissociative symptoms are only concerning, when you should be underlined, when they become chronic and defining features of a person's life. That it happens again and again. So people knowing that this guy dissociates all the times. Relevant clinical information for making a diagnosis, quantity as I mentioned, and frequency of the experiences. Cultural influences are dissociative states accepted as part of religious and social experiences. Many cultures, you must be knowing, I'm pretty sure in Arabic, Indian, other cultures, they have dissociative symptoms, and sometimes they're induced in a trance-like state. And associated with the mood changes, unexplained changes in the handwriting could be a subtle cue to somebody's that is dissociating. Amnesia, episodes of unusual or uncharacteristic behavior that is not common to the individual, unexplained sudden extended trips, we'll be discussing a bit more about that. Erratic behavior, having two or more distinct identity personalities. These are the pointers towards a diagnosis. So we'll be coming to the diagnosis in a short while. These are the common features, 5 core components of dissociative disorders. Got that, right? Amnesia, derealizations and depersonalizations. I'll be discussing those things with the definitions possibly in the next few slides. Identity alterations and identity confusion. All right? And this is about what the diagnostic classifications talks about, both ICD-10 and DSM-5. Dissociative identity disorder, amnesia, and fugue states, depersonalizations, derealization disorders, other and unspecified. Those are very often accompaniments of most of the DSM-4 diagnosis. I'm not going to the details of it. And yeah, these are in some more detail. This slide talks about dissociative amnesia, fugue, depersonalization, dissociative identity disorder. I think this is probably the summary of the whole discussion that we are making here so far as the diagnosis is concerned. Coming to amnesia, the person forgets important personal facts, including personal identity. For example, you won't know who for example, one he or she is, for no apparent organic cause they're talking about. Because with amnesia for the organic cause, you know, that happens. Here is one example. Dissociative fugue, a person moves away and assumes a new identity with amnesia for the previous identity. He goes to a different country, different state. Yesterday I was discussing about a gentleman in Kolkata. For a long time, an Anglo-Indian gentleman, he suddenly dropped from nowhere and was found to be roaming in the street and begging for food. And we did not know. For a long time he was known with a sobriquet as somebody, the foreign beggar, to call him. But eventually he was diagnosed, treated and sent back home. So that would be the enormous impact that dissociation could have. Depersonalization is a frequent, these are the terms we frequently use, frequent episodes where a person feels detached from their mental state. All right? And body. Dissociative identity disorder is commonly known as multiple personality disorder. You might have seen it. It's characterized by disturbance of the identity and memory. So we will be going, when we come to the diagnosis in particular. Other conditions with dissociative symptoms, substance intoxication, as I mentioned, it could occur. It's an interesting part in, for example, psychotic individuals. Schizophrenia could be a concomitant diagnosis. It's not that one has to have only dissociation without anything. That must be kept in the mind. Depression, personality disorder, malingering. So remember, always think about the possibility of another diagnosis, especially when it meets the full criteria. So types of amnesia, talking about it, it is in slightly more detail. Possibly it may not be exactly relevant to you, but for the sake of our discussion, we'll be discussing anterograde amnesia, retrograde amnesia, psychogenic amnesia. or organic amnesia. Anterograde is the inability to form new memories after the conditions producing amnesia occurred. For example, at this point there is an injury. So what happened subsequent to it? It's called anterograde. Retrograde, something that before that thing occurred. So that's what essentially it talks about. Psychogenic amnesia, amnesia due to traumatic or extreme stressful events, very common in our setups. We say due to trauma, abuse, terrorist attacks, for example, you are homeless, people go through this sort of period of amnesia, they don't remember anything. That serves a purpose for them. Organic amnesia, we discussed about that, head injury, drug intoxication, surgery, things like that. So this is again the DSM-5 diagnostic criteria. We have covered most of it, so I'm not going to the depth of it. Dissociative amnesia we're talking about. So maybe the clause 1, if you just read, that will give us a summary of the whole thing. An inability to recall important autobiographic information. Autobiographic means about your own personal life information, usually of a traumatic or stressful nature that is inconsistent with ordinary forgetting. Not dissociative amnesia most often consists of localized or elective amnesia. I can read the whole thing, unfortunately, because of the way the slide is made. For a specific event or events, or generalized amnesia for identity and life history. So the patterns of dissociative amnesia could be localized, selective, generalized, continuous. I'm not going to the depth of it again. Etiology, as we discussed, typically occurs following traumatic events, may involve motivated forgetting or traumatic events, poor storage of information during traumatic event due to over arousal. That could be the cause of how amnesia occurs. Dissociation during let's say avoidance of emotions during traumatic events, as well as emotional reaction to the events afterward. That could be the cause of amnestic events, although we are not clear about it. We don't know the exact cause of it. Extreme stressful life events we discussed already. So at the end, why you do that? We are looking for the treatment of the condition, isn't it? So our aim in treating dissociative amnesia here is, the goal is to help the person remember the forgotten traumatic events and resolve the stress depressing situation or the stressful situations. Coping skill is important. Non-specifically it helps. It has been seen that people who are having strong coping skill are more resilient, and they are unlikely to have the aftermath of dissociation. They can tolerate it more. For example, following a trauma, not everybody gets dissociated, only some people do. Alright. So intervention involves, as you can see, more about involvement of the family and significant others, more general sort of type of interventions. Trauma work. Here we are talking about CBT work. There's a process of trauma-focused CBT, cognitive behavior therapy. We talk about it. Hypnosis, might have heard, that has been used, and there are hypnotherapists especially focusing on this area. Dissociative fugue. This is a condition. I was talking about how people go away assuming different identities. Dissociative fugue has all the features of dissociative amnesia plus purposeful travel beyond the usual everyday range. Yesterday we discussed about an individual coming from asthma. He was supposed to come to Dubai. Instead of that, he went to Abu Dhabi, came back, and it happened several times in a week without any recall of what he did there. But we have got evidence that he went there, apparently to the petrol in his car, those sort of things. So it can go to that extent. Although there is amnesia for the period of the fugue, the patient's behavior during this time may appear completely normal to the independent observers. He did his all activities, but he could recall some of those details in sketchy detail. He is unable to recall some or all of his past. He is confused about his or her identity. Instead about that, may assume a partially or completely new identity. Etiology of dissociative fugue, more or less similar to the one etiology of other conditions. Stress or traumatic events, person may be physically, mentally escaping from a threatening environment, intolerable situations, chronic stress and depression. Particularly traumatic event I'm talking about when acute trauma suddenly it occurs. People are unable to cope. this serves a purpose, dissociation. As you know, dissociation could be a valid defense mechanism. Treatment of dissociative fugue states usually end rather abruptly on their own, as abruptly it begins, but for some people it might persist, as we discussed. Following the episode, person may or may not recall the events that took place during the fugue. Supportive psychotherapy help person identify, resolve stressors leading to fugue state and to learn better coping skills so that the fugue doesn't happen again. As you can see, medicines hasn't been talked about here. It is primarily psychological or psychosocial management we are talking about for all those states. This is a rather interesting state, depersonalization, derealization disorder, or triple D in DSM-5. So it talks about, so briefly, let me read the clause A for us to recapitulate. The presence of persistent or recurrent experiences of depersonalization, derealization, or both. So depersonalization is being defined as experiences of unreality, detachment, or being an outside observer with respect to one's thoughts, feelings, sensations, or body actions, as if you are seeing yourself from a distance. That sort of feeling, that as if feeling. Remember that. Derealization is more to do with your surrounding. Okay? Surrounding are changed. Experiences of unreality or detachment with respect to surroundings. Alright? So depersonalization about the person, individual, derealization about the surrounding. That's the crux for us to remember. I'm not reading the other components are probably more or less same for most of the other disorders. So in this condition, these 5 categories again, they were talking about the numbing of emotion and bodily senses. You can no longer feel the emotion completely. You're numbed. Feeling unreal, detached from the self, things in unreal realizations, distorted sense of time, and altered bodily perceptions. I found it interesting, and the source is mentioned there. Dissociative identity disorder, DID. This probably has received maximum media coverage and popular imagination. Movies have been made about it. You remember any
Split.
Particular movie?
Split.
Split is one. Dr. Jekyll, Mr. Hyde. You must have heard about that. Movies, books have written on that. So this is something that we might devote some time to discuss in some detail. Disruption, criteria A talks about a disruption of identity characterized by 2 or more distinct personality states. At least 2 personality states have to be there, which may be described in some cultures as an experience of possession, the possessive states for that. The disruption of marked discontinuity in self and sense of agency accompanied by related alterations in affect, behavior, consciousness, memory and perceptions, cognitions and sensory functionings. These signs and symptoms may be observed by others or reported by the individual. The individual can also to an extent report it. It's interesting, isn't it? It was that I have got 2 different states. In fact, the states are called as alters in psychology terms. The alter, one personality state. And we'll be discussing about a little bit more about it, that people can have more than one alter. Yeah, they talk about that. Presence of 2 or more distinct identities or personalities, at least 2 of these identities or personalities will currently take control of person's behavior. Alright? One person, Dr. Jekyll, changes to Mr. Hyde. Not necessarily in the night time, as it mentioned there, but it does. So recurrently, it happens that way. Inability to recall the important personal information that is too extensive to be explained by ordinary forgetfulness. Disturbance is not due to, again, effects of substances. That is a common denominator. 2 or more distinct identities, personalities, alters, as I mentioned, with their own perceiving, relating patterns. I have some few more minutes left, but Bharati, I'm going on time. And they alters are often unaware of each other, although to an extent some people can remember the other alters. Transition between the alter switches are usually abrupt and often triggered by stress or external cues. Self-mutilation, post-traumatic stress, conversion symptoms and suicidal behaviors are common in these situations. Remember, it could be very distressing event when they are going through this phenomenon. High incidence of the comorbid psychological disorders like substance abuse, depression, anxiety disorders can be there. So they might be a comorbid diagnosis with other conditions. By far, it's a fairly infrequent occurrence. As you can see, the prevalence is 0.5 to 1% in non-clinical samples. 3 to 6% of the severely disturbed inpatients in our inpatient settings. Possibly we might expect them to be more. If we are not diagnosing, probably we are missing them out. So almost onset, almost always in the childhood. Gender differences, women have got it more than men for obvious reasons, for the way women perceive stress and the prevalence of depression and anxiety conditions generally more in women. So women tend to have more identities than men as well. Versus 15 versus 8, 15 different states and average a person having a DID will be having compared to men. As I mentioned, course here tends to last a lifetime unless they've been treated in a particular time. Age, they frequency of switching may decrease with age. Gradually, they probably switch less because they have resilience. They have gained bit of how to cope with the situations. And the biological correlations demonstrate changes in the optical functioning in their ultra-kids. Etiology is more or less similar to other conditions, so there is no need to go through it again. For the brevity of time, I've got at least 3 more slides to go. The only thing of note, I would say, that the environment is often chaotic where they grow up, children, childhood, non-supportive family environment, and developmental window of vulnerability for the DID closes at approximately 9 years of age. Could be an MCQ question. So the incidents that occur before 9 years are probably more significant, more positive than what occurs later on. Possibly at a later age when it occurs, there were different ways to cope with it. Treatment of DID, goal is to integrate the alters, multiple personality into one coherent personality. Okay, there are multiple, we are trying to make him back to a single coherent personality. Identify each personality and its functions, roles and concerns, negotiate with personalities to fuse into one personality. So they are still amenable to negotiation, remember that. In that way they differ from a psychotic individual. Trauma work, here again we talk about CBT work, identify cues, triggers that provoke memories of trauma and dissociation, neutralize emotional charge in the memories hold by desensitization. These are classic techniques that they use in CBT, reliving the experiences. Help person develop adaptive strategies for dealing with stress. Use of hypnosis is common, but again controversial as a whole hypnotic practice is. Usually long-term psychotherapy is indicated. Antidepressants do help. Here is one of those dissociative conditions where medications have been utilized to an extent. And anti-anxiety drugs also have been used, but I should have made a disclaimer there. We must remember that we do not do any harm to the individuals. As medical doctors, we take an oath and don't encourage disintegration. Our aim is to integrate all the functions. So those are basically what I had in my mind while discussing. So now, if you come to our case that I discussed in the beginning, any thoughts about it? What could be the possible diagnosis in this Ethiopian lady, 23-year-old lady who presented with all those symptoms following a stressful event, backed by a family history, prejudicial childhood characterized by witnessing violence by his alcoholic father. All right? I just am giving you some cues to that. So, what the lady might be suffering from. Open for discussion, basically. Anything? The possibilities here?
So she fugue because she ran away.
She ran away.
So, yeah.
It's possible, but in the fugue state, one essential criteria, if I go back to the slide, is that she must be forgetting, she must not be remembering all the details of the past. Yes, it possibly could be. To be very frank, at the end of the day, we were not able to diagnose her. We thought both in that category of others unspecified category we kept because of the lack of evidence. We were not able to interview her properly because of the language barrier. And when you did, she just gave this traumatic history and couldn't corroborate most of the symptoms. So possibility of a fugue state is there because she was found roaming in the streets of Dubai before being caught by the police and taken to the embassy. And also it could be derealization in the sense that possibly she didn't know the situation that she was in and she was not clear about it. But as I mentioned, we didn't have a clear-cut diagnosis at the end. Alright? So, and very often that is the case. Very often we are not able to make a clear-cut diagnosis, especially when the evidence is not clear. So the point of what I wanted to make here is that people presenting in states, transient psychotic-like states, or states of acute stress reaction like situations, please keep in mind the possibility of dissociation or dissociative disorders. Because once you diagnose it, medication is not the answer. We usually try to address the issue more by the say environmental management, structuring environment, and improving person's coping styles, coping strategies, which is much more effective and cost effective than medications. We had the theme yesterday in our discussion that it will be like we have to think beyond medicines. So this is possibly one of the conditions that we miss in our day-to-day practice, and hopefully by focusing our attention on it, we'll be able to give a better service to the patients as well as save money from our service, because otherwise medication is costly and it has its own unnecessary side effects. If there's nothing else, thank you.